because this is part of the Twin Trust webinar. So the Twin Trust is a charity of the UK, Twin and Multiple Pregnancy. They jointly with St. George's University and the Trust set up the first Twin Trust Center for Research and Clinical Excellence. That was back in 2020, and we've been, as part of the activities that we do, is that we have this regular webinars, it's mainly educational webinars, and at the moment we're doing it monthly. So these webinars are recorded and they're available also on the website for people to access. We have a lot of registration, and roughly about half or a third of the people who actually register join live, but they have access to the recording. They also have access to certificate of you being have attended the webinar, and also the feedback. We really wanted to be interactive. I personally enjoy the discussion. I think it's a fantastic opportunity to have really the eminent experts in this area, that being with us today, sharing expertise, 15 minutes, summary of the article, and then having the discussion. So please feel free to engage and ask questions. We tend to mute everyone so that we don't have any interruption of the speaker. And therefore, if you want to have any questions, please use the chat function to post your questions. I promise I'll make sure that we go through all of them. So the last talk, and I'm sure it's one of the best, is on twin anemia polycythemia sequence, or TAPS, another controversial subject. And is we have here Professor Ahmet Baschat, who is the head of the fetal therapy program in Johns Hopkins.
Yes, thank you very much for inviting me to speak and to participate in this. Can you see the presentation?
Yes, we can see it.
Okay, great. So my talk is about TAPS, and I wanted to review a few important features of the placental angioarchitecture, because TAPS is a kind of condition that was only recognized with increased incorporation of Doppler studies into the evaluation of monochorionic twins. So just interesting to review, before prenatal diagnosis of TDTS was, known to us, actually TDTS was identified by pediatric criteria for hemoglobin differences. And when TDTS was discovered, we focused very much on volume differences. And then when we started using MCA Dopplers, we recognized, oh, there's actually another disease here that might actually present as well as a separate disease entity. So this is an injected placenta. We inject all of our monochorionic placentas that deliver at our place. And there's some important features that sort of determine what the risk profile of the condition might be. So all monochorionic twins have anastomoses. Large artery to vein anastomoses have been implicated with unidirectional volume transfer that then basically predisposes the donor twin to hypovolemia and the recipient twin to hypervolemia. And in this kind of disease pattern, the main issue is volume discordance. And in fact, the red cell mass is fairly comparable. Now, there are also small diameter artery to vein anastomosis, typically classified as less than 1 millimeter in diameter. And here you have less intervillous space in between, and there's a more direct transfer in red cells. And in these kind of anastomoses, if there's unidirectional transfer, it actually predisposes the babies to a difference in the red cell mass and hemoglobin value, and where you then have a donor that is actually anemic and a recipient that is polycythemic. And the volume differences characterize the condition that we know as twin-twin transfusion syndrome, versus the differences in blood count, which basically characterize twin anemia polycythemia sequence. which can occur prenatally and it can occur at the time of delivery. There's a third feature of this placenta that I'm not going to specifically go into, but as you can see, one twin has a cord insertion that's very much at the edge of the placenta. And the meeting point between these anastomoses is very much towards the side of that baby. And so here the equator, which is sort of the imaginary line between these meeting points, shows that one baby has a much larger placental share than the other one. And that does become relevant in the differential diagnosis. But I was going to talk more about the specifics of TAPS in this talk. So spontaneous TAPS is basically twin anemia polycythemia sequence that occurs without any prior fetoscopic laser surgery. And so when you look at these placentas, they're characterized by 3 to 4 AV anastomoses that are typically small in diameter, and that is relevant in the treatment approach. And less than 20% have compensating small artery-to-artery connections. Compared to post-laser TAPS. So post-laser TAPS is basically TAPS that occurs after incomplete laser surgery. And here what you find is predominantly that 1 to 2 small AV anastomoses have basically been missed or have been partially coagulated, and they are very sporadic compensating AAs. This kind of constellation on the placenta predisposes to a slow blood transfer, usually less than 15 milliliters a day. And what happens in the baby that loses red cells, there is stimulation of the erythropoietic system. Whereas in the recipient twin, which receives more red cells, there's actually downregulation of erythropoiesis, pretty much to what you would observe in a baby that's being transfused. So the donor baby mounts a compensatory response that is characterized by increased reticulocyte counts, and the recipient does the obvious, they downregulate their hematopoiesis. Now, if this compensatory response is unsuccessful, the donor gets anemia and the recipient polycythemia. And what that is associated with in the ultrasound surveillance is that the anemic baby gets an increase in the peak systolic velocity in the proximal middle cerebral artery. That is a response that is very consistently found in babies. What we also observe in the polycythemic twin is a decrease in blood velocity in the same vessel. Now, it's important to recognize that an increased MCA peak systolic velocity in response to anemia is something that has been more consistently studied and more consistently demonstrated than the opposite. So we know that a baby that has a high MCA is likely anemic, but we can't really estimate what the increase in the blood count is going to be in a polycythemic twin. There are other secondary findings that you can observe in these pregnancies, so that the donor twin has a more echolucent placenta, and that there's differences in placental echogenicity. Sometimes you can actually see where the meeting point, the vascular equator, is in this area. The polycythemic twin is often found to have a liver that has sort of little echogenicities that have been described as a starry sky liver. And the other thing that's also important is that there is a high rate of coexisting fetal growth restriction in the donor twin, which complicates about 40% of TAPS pregnancies. So that's sort of like the clinical picture. The baby that is anemic is at risk for the same cardiovascular decompensation that we see in anemia from other causes, whereas the recipient is at risk for hyperviscosity syndromes both prenatally and postnatally. Now, the TAPS diagnosis and staging system has sort of evolved over the last 12 years. It was first described by the Leiden group, which basically defined the diagnostic cutoffs that identify stage 1 TTTS based on one baby having an MCA peak systolic velocity over 1.5 MOMs and the other one less than 1, and then an increase of this discordance identifying stage 2. So that's a really progressive discordances in the blood flow velocities. And then the higher stages, stage 3, 4, and 5, are really adapted from the traditional Quintero staging. But the important one was like, when do we call something TAPS? The staging criteria were sort of then revised later on in 2019, where the emphasis went from the absolute value to actually the amount of MOM discordance, because this is associated with the degree of hemoglobin discordance and can sort of capture the pregnancy irrespective of the absolute MOM value of the MCA-PSV. The higher stages for the TAP staging were basically carried over, and that did not change. And then the most recent addition was the Delphi consensus, which basically identified one other important parameter, which was the discordant MCA. Kurt's group had previously published that an MCA PSV discordance of over 0.375 actually correlated with significant hemoglobin differences at the time of delivery. This is a questionnaire consensus study, which basically said, like, well, if it's over 0.5 MOM, then you can call it discordant MCA. And if the discordances exceed 0.8 MOM or the MCA-PSV in the anemic twin is over 1.5 MOMs and the other recipient twin has 0.8, then you can call it TAPS, and the staging is not further qualified in here. The importance of identifying a discordant MCA value is because it has implications on the surveillance frequency and when you should increase your surveillance frequency, and I'll come back to that in a minute. And then there is also a postnatal classification of TAPS, which is basically simply on the hemoglobin differences between the twins observed at the time of delivery. Another important clinical factor that is important to consider, I told you that TAPS can happen prenatally, spontaneously, or it can happen after laser surgery, but it can also certainly happen in the intrapartum process, because the shunting dynamics across sort of dormant anastomosis can be affected through labor. And you basically distinguish intrapartum TAPS from chronic prenatal TAPS by looking at the ratio of the immature red cells. Remember, when a donor has time to mount a hematopoietic response, they're going to have a high reticulocyte count, and the opposite is going to exist in the recipient. When TAPS happens intrapartum, there is no time for that process to take place because it's too quick. And in these babies, the reticulocyte ratio between the donor and the twin will be less than 1.7. And it's always interesting to look at the placenta afterwards to see if there are any placental anastomosis. So the distinction between chronic TAPS requires a differential red cell count of the babies at delivery. Now, we talked about Doppler and the screening strategy for monochorionic twins. There are high-risk profiles that determine our screening frequency, and there are findings that basically increase our surveillance frequency from every other week to weekly, because when these findings do happen, then there is a higher likelihood of evolving into clinically relevant disease. So depending on how strict you want to be, or how sensitive you want to be monitoring your babies, once you observe an MCA discordance over 0.375 moms, you may want to switch from every other week to weekly surveillance of monochorionic twins. If you want to be a bit more restrictive, you may want to pick 0.5 MOMs. I think there are differences in practice, and that's certainly not identified in the guidelines. The thing that is different about TAPS versus TTTS, So TTTS twins have no really good physiologic mechanism to counteract the volume imbalances. So a donor can't just produce more volume and the recipient can't get rid of more volume, but a donor in TAPS can make more red cells, especially before 28 weeks when you have a wider hematopoietic pool available to yourself. So the clinical progression can be slower, and that's the argument where you might say like, well, I can be a little bit more lenient and only increase my surveillance when I'm at 0.5 MOM. And these babies we typically follow weekly. Now, the other thing that's also important is that the diseases that we see in identical twins and that we presented don't necessarily happen in isolation. So about 10 to 15% of our TTTS pregnancies have coexisting MCA discordances as well. And that correlates with what you're going to find on the placenta at the time of laser. So TAPS can exist as its own disease. It can exist in association with TTTS, and it can certainly exist in association with SIUGR. And I think anytime you want to assess a monochorionic twin pregnancy, you want to sort of get an idea whether the predominant issue in these babies is amniotic fluid discordance. So is this more like a volume discordant twin pregnancy, whether it's a size discordance because it tells you about the vascular equator, or whether there's hemoglobin discordance, or there's a coexistence of all of these diseases, because that has impact on the treatment approaches. The treatment for TAPS pregnancies when they're diagnosed is not yet ideally determined. A large multi-center study looked at the treatment approaches that were used in a large number of fetal therapy treatment centers with the options for expectant management. So basically just follow them with a threshold where you are forced to intervention, offer a primary laser surgery, and typically the Solomon laser, because that lasers the whole equator. The other alternatives are selective reduction, either by cord coagulation or RFA or microwave, or then transfusion or exchange transfusion of the twins. Now, when you do transfusion treatment, it's important to recognize that you don't just transfuse the donor baby that is anemic, you also do an exchange in the other baby, which is a more complicated procedure where you withdraw blood volume and replace it with saline. So it's a little bit more of an operation than just a simple blood transfusion, or the option is then also delivery. And I just put the slide in the preceding 2 hours just to illustrate the differences between the different laser techniques, just to talk about the strategy for laser surgery in TAPS. So when laser was originally described, it was a non-selective technique that oriented itself by the membrane, because there was a sort of visually identifiable thing. So everything that crossed the membrane was coagulated. That left a small portion here of placenta, usually for the donor twin. And then the selective technique basically only coagulates the anastomoses that truly connect the babies with each other. And then the Solomon laser uses this selective technique, but also coagulates a line across the complete chorionic plate, therefore sort of doing a complete separation. So those are the differences. Now, when you are planning treatment for TAPS pregnancies, there are some important considerations. So the efficiency of laser surgery for TTTS is very well established, but that relies on your capability to reliably visualize and access the equator. So one of the ways that you sort of plan your laser surgery, and that is important in TAPS pregnancies, looking at where the cord insertions are, you have an inkling where the vascular equator is going to be oriented. The orientation of the stuck twin tells you where the membrane is likely going to be. And if there's associated size discordance, then you know that the equator is more going to be on that side. And that kind of preoperative assessment is fairly reliable, especially with the position and the course of the equator. Now, what is important in TAPS pregnancies may not have coexisting volume imbalances. So what you have to ask yourself is, are you going to be able to get in one sac where you're going to see the equator in its entirety? Because if the membrane is in front of the equator and there's fluid behind it, you're not going to be able to visualize the vessels as well as you would if there was a stuck twin. And this is important because the vessels that you're trying to identify are also tiny. So whatever visual limitations you might have, they're going to be amplified by that. So when we make a treatment choice about laser or not laser, I think one of the things that we look at specifically is the reliability of access to the equator. Now, in this study by this multi-center group, the characteristics of the treatment approaches were basically that an expectant approach had a median sort of diagnosis to delivery interval about 8 weeks. Most patients delivered in the 3rd trimester. About 12% required subsequent treatment for worsening TAPS. And that is pretty characteristics that there is a compensatory mechanism and those babies might actually remain stable, but 12% required subsequent treatment. Laser and selective reduction had the longest interval between diagnosis to delivery, and but laser had a higher rate of subsequent treatment requirements, either in terms of transfusion or a secondary reduction. And the IUT treatment approach had the shortest sort of latency to requiring delivery, on average about 4 weeks, and a high number of babies required subsequent treatment. So at the moment, all of these treatment approaches are utilized, and which strategy you're going to follow depends on several factors. Important one is the stage and severity of the disease, and then the gestational age. And then in terms of the treatment is the access to the equator. So if a pregnancy presents early on, so early on 20 weeks, 19 weeks or so, and it's a stage that is 2 or higher, the likelihood of progression is greater, but the time that you're going to gain to a meaningful gestational age is going to be challenging with expectant management or IUTs, and that may force you then to decide laser surgery versus selective reduction. And the choice between the two of them really depends on the access to the equator, and you may have to decide that sometimes intraoperatively. So here in the manuscript, I had sort of, we had summarized some of the characteristics of the different treatment approaches and when you might consider basically one approach over the other. And the basic gist of it is the earlier that it presents, the more you're forced to have a definitive treatment response that's going to cure the disease. And the later you are in pregnancy, the more you might go to expectant or IUT treatments that might give you a acceptable gestational age at delivery, with the focus on temporizing treatment. The overall prognosis of TAPS depends basically on the severity of the condition as well as the therapies taken. So basically, postnatal TAPS and hematologic abnormalities that require additional management after the delivery is basically avoided when you are doing a selective reduction, and it can be up to 14% after laser, and that is basically due to residual anastomosis that you did not occlude in the laser surgery. The other approaches, because they're temporizing measures, so IUT or expectant management, are associated with a higher rate of hematologic abnormalities at the time of delivery. Postnatal transfusion needs is basically the lowest for babies that underwent surgical treatments, and up to 60% with others. And the treatment approach is basically the same: transfuse the anemic baby and do an exchange on a polycythemic recipient. Neonatal complications are related to prematurity, and as a rule of thumb, delivering before 30 weeks has a significantly higher impact on neurodevelopment outcomes, and the rate of neonatal complications as well as neonatal mortality basically goes down between 1.5% to 2% a day from 26 weeks onwards. So depending on the time of delivery, 27 to 53% of pregnancies have prematurity-related complications. The complication rates are higher for babies that have received IUT or were delivered immediately. And there's also a significant difference between babies that experience post-laser TAPS versus spontaneous TAPS. So post-laser TAPS is essentially a failed laser for TTTS, and these babies have the issue of maybe incomplete recovery from a TTTS with a secondary disease on top of that. So the neonatal mortality is 2 to 3 times higher than what you observe after spontaneous TAPS. In terms of developmental impacts, the same is that post-laser TAPS also has a higher rate of brain injury and developmental impacts, and that is partly due to the double disease impact of TTTS and TAPS, but also the earlier gestational age that these babies have to be delivered frequently. The rate of brain injury for spontaneous TAPS is in a region 2 to 7%. The overall developmental impacts are about 10 to 15%. There is 15% deafness and a 4-fold increased developmental delay risk in spontaneous TAPS that is predominantly affecting actually the donor twin. And the developmental delay relates to the severity of the condition, the prematurity, and the presence of coexisting FGR. And that is because the TAPS donor is more frequently affected by IUGR, which affects both the clinical evolution, the delivery criteria, as well as the condition of the baby at birth and the time when delivery needs to happen. So in conclusion is that the angioarchitecture of the placenta determines the clinical phenotype of twin pregnancies. The TAPS pregnancy is characterized by small diameter vessels, but there can be overlapping features with TTTS and SIUGR as well. The sequential ultrasound and MCA Doppler screening and the adjustment of the screening frequency is really key to capture the disease. And MCA Doppler is just necessary to diagnose TAPS. So not doing MCA Doppler basically would mean that you're not interested diagnosing this condition, period. And you may choose to do so because optimal treatment has not been yet determined. And that is unfortunately a standpoint that many professional societies take because they feel responsible to defining a standard across a healthcare system. And this is where fetal interventionalists often disagree with the professional societies. Morbidity and mortality is multifactorial and includes the severity, the type of TAPS, gestation age at delivery, and the coexistence of FGR, which is quite frequent in this condition. Thank you.
Fantastic. Thank you so much for the wonderful talk and overview on TAPS, twin anemia polycythemia sequence, highlighting also some of the controversial and the challenges that we have in the lack of evidence on what is the most or the best treatment, and also highlighting the fact that it's associated with excess neonatal morbidity as well as perinatal mortality. I'm going to start with a couple of questions. So you did highlight that the fact that the professional societies say, well, we don't know what's the best treatment, and therefore we don't want to screen for it or monitor for it. The other argument that, having sort of sat on a nice committee and we had this discussion, is some people say, well, sometimes you have this discordance in MCA Doppler, or maybe would fulfill the diagnostic criteria for maybe stage 1 TAPS. And then you see this patient a few days later or next week, and the MCA Doppler goes back to normal, or the discordance disappears. How do you explain that?
Well, I mean, so the thing with the MCA is it is more variable, and it's influenced by other factors than just the downstream vascular resistance. It has to do with maternal sugar levels. You have if you have coexisting FGR, like a higher level of PCO2 can affect the MCA peak systolic velocity, and you have to scan the babies when they're not jumping around. I mean, and you need to use the most reliable waveform, you know? So there are some more variations. And I would say, like in our series of blood samplings that we've done over the last, 5-6 years, there are a fair amount of babies that have significantly elevated MCAs that have a completely normal, hemoglobin, and that does exist. I think from a society perspective, right, you can take two approaches, and you say, like, don't do MCA Doppler until you figure out what to do with it. Or if the MCA is abnormal, send them to a specialist to get their input, right? And ultimately, that's the safer thing to do. I mean, it's 2022, right? I mean, so that's kind of my perspective. And we do have patients that are not that severe, or they normalize, but then we make a surveillance plan and say, you know what, you follow them until you see this. The other thing that I would say is we use more secondary Dopplers as well. So if we have an MCA that's up, we're using the old reference wages for the thoracic aorta mean velocity, and we look at the splenic artery as well. And the babies that are truly anemic, all of that is up. Right, so that's something that we use, but that's a referral center, right? I mean, that's the point of referring those patients. Don't necessarily try to figure that all out yourself, but get an expert advice and then co-manage them. That's how I would approach that.
Yeah, totally agree. I mean, another point, you did mention that post-laser TAPS occur because we missed anastomosis, or because it's partially coagulated. Because sometimes when you go back for the repeat laser for the post-laser TAPS, you don't necessarily see a missed anastomosis, but you see some blood vessels that sort of partially coagulated. So there's some little bit of blood flow. How do you try to prevent that? Do you just coagulate them twice, or do you use higher energy with the laser?
Yeah, I mean, I usually coagulate them wider out and try to get an area where it's distinctively wide. I have to tell you that sometimes you also have vessels where you wouldn't have been able to see them from your vascular from your access into the uterus. So we also had vessels that were behind the entry, right, where we then entered from the other side, knowing what the equator was like. So yeah, but I mean, I just coagulate them until they're wide.
Okay, fantastic. Kurt, you have a comment or question?
Well, I just want to say, if you have a TAPS after laser, first of all, don't panic. Just wait and see, because there is a high rate of spontaneous remission in these cases anyway. And that could be effect of the laser, of course, because one of the explanations could be that the donor increases its volume, but it would not increase its concentration on erythrocytes the same way. That takes longer. So there will be hemodilution, and the other way around in the recipient. So first, wait and see what's happening, and about half of them will show spontaneous remission.
No, I mean, I totally agree. And I think the other thing is that the MCA takes really much longer to normalize after laser when you follow the peak systolic velocity. So, I mean, I would seriously wait for 3-4 weeks before I make a decision on that, unless you see something like high drops or something. That's a different thing. But, other than that, yeah. it's always bad to panic. That's something that I learned from Kurt. It's always bad to panic.
Yes, and in fact,
It doesn't help at all.
No, and if you look at the literature, a lot of the studies, even by the Dutch group, they would define the post-laser taps with the taps that occur after at least 1 or 2 weeks after the laser for GTS, because to avoid the effect of the hemodynamic changes after the laser. So you're right, we will not intervene, except if it's hydropic, for example, if it comes out when it's hydropic, where you, and with very abnormal Dopplers, particularly the ductus venosus, where you have to intervene. Fantastic. Any other comments or questions from the panel or the delegates? And just to say, we've been almost 3 hours in this workshop, which I have to say, I thoroughly enjoyed it. It was really great, and really grateful to the experts who share their time on a Sunday to come and talk to us and share their expertise, and actually really to highlight the work that they've done with this paper. So really encourage everyone to download and read these articles and cite them in your future research, because they're really very, very valuable. So I'm gonna finish this webinar, but again, thanking the speakers, thanking the delegates, the people who actually joined the webinar and stayed for 3 hours, and highlight that the recordings will be available with the publisher, Elsevier, and also the Twin Trust, for people who registered to, and other people who haven't registered to also access. And just to highlight that these articles are have also a list of practice points of the research agenda. So if you are a researcher and looking at what's your next research project, and MCQs for people who want to have some material for their demonstration of your ongoing education and training. And just to highlight that this special issue had 21 articles. So these are the 6 of these articles that were presented and highlighted today. The next webinar was going to also focus on the special issue, would be on the 18th of December. So again, it's a Sunday in December. And just finally to thank Elsevier and the publisher for really highlighting and supporting this initiative, and for the staff, the journal staff, and for amazing the fellows, and particularly Jamila, who's helped with the coordination of the webinar, and she's sort of behind the scenes making sure that there's no technical problems. So on this end, just to say thank you very much. Enjoy the rest of your Sunday and have a lovely week. Thank you.